We have 47 participants. 10 of them are missing. Anyway, I'll get started. We are almost there. Okay, case number 36. A young man is shot point blank in the lower abdomen just above the pubis. He has blood in the urine with no evidence of rectal injury. So if you're shot in the pubis, what's the most likely source of bleeding? Bladder injury. And when you have bladder injury, how do you confirm the diagnosis? Retrograde cystogram. And when you confirm that the patient has retrograde cystogram with leak, surgical repair. A woman is shot in the flank, and when a Foley catheter is placed in the emergency room, the urine was found to be grossly bloody. Another example of urinary tract injury, location being flank. Where was the hemorrhage be coming from? Renal. And you know, both these cases are gunshot wounds, so they'll both require surgical exploration. A 22-year-old man involved in a high-speed automobile collision has multiple injuries, including a pelvic fracture. On physical examination, there is blood at the meatus. What is the next step in the management of this patient's condition? Choices given will be: number 1, do a Foley catheterization; number 2, do a suprapubic catheterization; number 3, do a retrograde urethrogram; and number 4, call urology. What was 3? I don't remember what I say. Retrograde urethrogram, absolutely. Now case number 38 is one of the simplest examples, but retrograde urethrogram, remember always it will be pelvic fracture, always remember it will be a male, always remember there will be some problem related to urination. Either he wants to pee and he cannot pee, or there is blood at the meatus, or that the penile shaft has bruising or hematoma. All these are, or scrotal enlargement, all these are suggestions that there is urethral injury. And the reason why we are worried about this case is because many inexperienced physicians don't realize that when they have a pelvic fracture, urethral injury in a male is a rule rather than an exception, very common. So say this is the urethra, right? And say somewhere along the urethra there is an injury, a partial tear, very common with the urethra, right? Insert a Foley catheter. You can actually go into the side tract and creates a false passage. That can actually rupture the urethra or transects the urethra completely, and now you have a urethra that looks like this. Now that is a tragedy. Why is it a tragedy? It is a tragedy because now you need a major repair to get this back together. And when you have a transection, you're going to join these two urethral ends together with a rim of with tiny little sutures. So you're going to have this anastomosis right here with tiny little sutures, and they will heal with scarring and stenosis. So in the long run, this person's urethra is going to look like this. So in the long run, you're going to develop a urethral stricture. And if you develop a urethral stricture, then the repair of urethral stricture will cause more strictures. And these people will need to put in a dilator every now and then to keep their urine from getting retention. All because an ill-informed physician pushed the Foley catheter through a partly injured urethra and converted into a complete urethral injury. This has happened before. That is why USMLE has made it its objective to assess all of us to ensure that we are aware that whenever you have pelvic fracture, with the suspicion high for urethral injury in a male, please don't attempt a Foley catheter. Always ask for a retrograde urethrogram. Okay, getting the slides back now. Okay. So case number 38, a 22-year-old man involved in a high-speed automobile collision has multiple injuries including a pelvic fracture. On physical exam there is blood at the meatus. Ask for the uretrogram. A 19-year-old man is involved in a severe automobile accident. Among many other injuries, he has a pelvic fracture. He has blood at the meatus, scrotal hematoma, and the sensation that he wants to urinate but cannot. Rectal exam shows a high-riding prostate. This is a house full. You have blood at the meatus, scrotal hematoma, sensation that he wants to but cannot urinate, and on rectal exam high-riding prostate, which suggests that instead of anterior urethral injury, it's a posterior urethral injury. But again, the management does not change. Don't put a Foley catheter, do a retrograde uretrogram. A 19-year-old man is involved in a motorcycle accident. Among many other injuries, he has a pelvic fracture. He has blood at the meatus and scrotal hematoma. A 22-year-old man involved in a high-speed automobile collision has multiple injuries including a pelvic fracture. At the initial examination, no blood is seen at the meatus. A poorly informed intern attempts insertion of a Foley catheter, but resistance is met. What do you do here? If the resistance is met, back off. Don't try and force or push the Foley catheter in, because it's again an injured urethra and you should do a retrograde uretrogram for the simple reason that once you identify that the patient has a partial tear in the urethra, then the urologist can put in a flexible cystoscope. Under direct vision, they pass a guide wire, and over the guide wire, they pass a catheter. And when you have the catheter in place, partial tear in the urethra will heal over the catheter as its scaffold. Exactly the same situation we did for tracheal laceration, and we put the nasotracheal intubation with the bronchoscopic guidance. Same principle applies here. You don't convert a partial injury to complete injury, because partial injury is treated non-operatively, complete injury is treated with surgery with sometimes poor results. Retrograde uretrogram. Do you see anything wrong here? Is it normal, abnormal? There is a leak. Absolutely. Let me show you the leak. So the leak is, you see, all this is extravision of the contrast. So I think somewhere here there is an injury from where the leak is going on, and if you see that, call the urologist. Okay. A 22-year-old woman involved in a high-speed automobile collision has multiple injuries including a pelvic fracture. Insertion of a Foley catheter reveals gross hematuria. So a woman involved in a pelvic fracture will most likely have not a urethral injury, but most likely will have bladder injury. So if you put in a Foley catheter, it will go in easy. But when the outcome is hematuria, what is the next step in the management? Instead of retrograde uretrogram, you're going to order a retrograde cystogram. Not cystoscopy, retrograde cystogram. Okay, David? Cystoscopy, I mean, you know there is an injury. So a radiological imprint of the bladder is much better. And it's much better because it's going to show you whether the rupture is, there are two types of bladder injuries. If you talk about the bladder injuries, the bladder bladder perforation is of two types: extraperitoneal and intraperitoneal. Is bladder an extraperitoneal organ or is it an intraperitoneal organ? Bladder is intra, somebody is saying extra, somebody is saying intra. Most of you are right, it's extraperitoneal, not partial. So let's make a diagram here. Just shows that you guys haven't been taught anatomy very well, huh? Look at this. This is the skin of the abdominal wall, right? This is the bladder. I'm looking at it from the side, right? This is the urethra going out in the vagina, right? And this is the peritoneum. So bladder lives between the peritoneum and anti-abdominal wall. So does it make it intraperitoneal? Even if it is distended and bulging through the peritoneum, it still is extraperitoneal, right? Yeah? It's an extraperitoneal organ, it's not an intraperitoneal organ. Okay? So there are two types of ruptures of the bladder. One is when you have intraperitoneal rupture with the peritoneum gone from it, and the other one is extraperitoneal rupture where the pubic bone from a fractured pelvis pokes into it and creates a puncture. So if it is extraperitoneal, which is here, then the treatment is just to put in a Foley catheter and drain the bladder. Leave the balloon, inflated balloon of the Foley catheter in the bladder, and just drain the bladder. And just leave the Foley in there for like maybe 2 weeks, maybe 3 weeks. And at the end, do a cystogram and you will notice that there is no extravasation of the contrast. Bladder heals because it's surrounded by a potential space. It's not a free space. It's just an abdominal wall in front, peritoneum behind. It is injury within these potential spaces. So if you keep the bladder collapsed by draining it, the bladder will heal. And when you re-inject the contrast 3 weeks later, there will be no extravasation. And you can then take the Foley out. It will be just fine. So that's the treatment of extraperitoneal rupture or perforation, which usually happens from pelvic fracture, as the case is in this situation. Intraperitoneal is the bladder bursting open inside the abdomen. When do you see that? When do you see intraperitoneal rupture? Asma, what is that? Try. Yeah, intraperitoneal rupture requires surgery, I know that. But it's not a trigon injury, it doesn't have to be. Most of the intraperitoneal rupture is actually a dome of the bladder injury. Okay? Yeah, Julieta, I will agree with you. C-section can do that. But that's not the mechanism of injury. The mechanism of injury is as follows. I had 2 cases, the mechanism of injury was the same. When I was training in Ireland, one of the requirements of the Royal College of Surgeons was that all the surgical candidates taking their fellowship at the Royal College of Surgeons must spend at least 6 months in the emergency room. So I had to, spend my 6 months to do my requirement. And one fine evening, actually early morning on Sunday, well, about 2 in the morning on Sunday, I was covering the emergency room, and I noticed that 2 Irish gentlemen are coming into my emergency room. They're brothers. One of them is in agony, other one is kind of supporting him. They're both big burly guys. And the story was that they were drinking. Irish love drinking, as you know, they love their Guinness. And they were drinking, and they usually start drinking on Thursday evening. If you have to have an Irishman drink, they don't get the high on it till they have at least 3 days of drinking on board. So their weekend for drinking actually starts Thursday evening and goes right through to the wee hours of Sunday morning. So this gentleman was drinking in the pub, and finally on Sunday, on Saturday evening it would be, he returned home. Obviously he had to go to work the next day. So Sunday evening, as he returned to his house, he was so drunk he slipped on the footsteps to the door, and he hit his pubis against the footsteps. So you can imagine that the bladder was full. Alcohol is a diuretic, and his bladder was full, and he fell on his full bladder, and the edge of his footstep of the house hit him right in the pubic area. And it resulted in severe pain. So he came to the hospital with his brother in agony. So, I said, okay, well, let's find out what's going on. I examined his abdomen. His abdomen was diffusely tender, But he was moaning and moving, he was intoxicated, so his physical examination was not very easy. So I put in a Foley catheter, and what I see is amber colored urine, about 20 cc's, dark urine came out, nothing else. So I said, okay, this was my second year in training in surgery, what do I know? I said, okay, let's put the banana bag, let's hydrate him, the guy is dehydrated from alcoholism. We started doing that, and no urine coming out. Okay, next morning, because in Ireland's poor country, we are not allowed to do CAT scans. So this was all clinical and physical exam. Next morning, the boss comes and I tell the boss, I've got this guy with unexplained abdominal pain after a fall at the footsteps of the house. I have no idea what's going on. His serum enzymes are all normal, and he has, very little urine output. But I don't know what's going on. His amylase is normal, his lipase is normal. I don't think he has pancreatitis, but I have no idea. He said, okay, never mind. We're going to stick in a laparoscope and see what's going on. Sure enough, we brought him to the OR, put in a laparoscope. When you are doing a laparoscopy, you have to insufflate the abdomen with carbon dioxide in order to see things. So we went in and we insufflated the abdomen, and what we see is a large amount of ascites all over the abdomen. We have no idea what's going on. Where is the source of ascites? His liver looked healthy, his pancreas looked healthy, his amylase lipase were normal. It couldn't be pancreatic ascites, it couldn't be cirrhosis causing ascites. What is the source of this fluid in the abdomen? Free, straw-colored, watery fluid all over. Yes, Rohini, yellow, dirty fellow. Okay. So while we were trying to figure out what's going on, our circulating nurse said, there is air coming in the urinary bag. And the moment she reported that, we turned our attention to the pelvis, got him head down, and there we see the bladder with the dome perforated, burst. So he had a true intraperitoneal rupture of the bladder. It happens when the bladder is full and you get a sudden pressure on the bladder and it bursts like a balloon. That's the mechanism, blunt abdominal trauma. So obviously we had to repair his bladder injury, which we did, and he did fine. After a few days he was sent home, and after 3 weeks we did a retrograde cystogram. Our repair has healed, we took out the Foley, he did fine, went back to drinking. The second case was about 10 years later. I was, by this time, in the United States. I was on call for trauma at the LAC USC Medical Center. And my third year said, Dr. Faruqi, we've got trauma, blunt abdominal trauma. I said, what's the story? Homeless man, drunk, sleeping at the curbside, turned and slipped off the curb and was on the side of the road. A big cleaning truck went right across his abdomen. So he had huge tire marks on his chest and abdomen. He came in with severe abdominal pain. His upper chest and face had multiple petechial hemorrhages, huge subconjunctival hemorrhages, and the guy was in agony. We took him to operating room, explored him. We found out that he had a ruptured intraperitoneal bladder rupture and a laceration in the right hemidiaphragm. What do you call this condition? This is called traumatic asphyxia. The mechanism of injury that I just talked to you about. Traumatic asphyxia. Basically, traumatic asphyxia is a condition where the abdominal cavity pressure or thoracic cavity pressure suddenly rises severely, giving rise to petechial hemorrhages, subconjunctival hemorrhages, diaphragmatic injury, and bladder injury. Yeah, he did fine though. I mean, we repaired his bladder, we repaired the hemidiaphragm. Those were the only two injuries. Washed him, closed him, he went home. He lived. Okay? So now you know two types of bladder perforations, intra and extraperitoneal. Okay, let's go back to the slides, please. You know, asthma surgery is very interesting, you know. It really is. Keeps you on your toes, keep your adrenaline pushing. It's exciting. Medicine, Medicine, come every morning, everybody's lethargic, tired, bored, miserable, they are miserable with themselves, miserable coming to the hospital. Look at the patients every day, from one patient to another patient to another patient to another patient, just changing the pills, the color of the pills. There are 15 people surrounding a professor. Professor is standing there with the face in his own hand and moving his fingers like his face is a piano, thinking about what to do next. Patient is not getting better. Alright, so far we have tried the pink pill for about 10 days. Nothing has happened. Let's change it to green pills. And then if nothing happens after a few days, they change it to blue pills. And then finally they say, I don't know what's going on. Call a general surgeon to figure out what the hell is going on with our patient. So it's quite miserable actually, Francisco, whether you like it or not, but that is the truth. Anyway, in surgery, it's all about action. And you know what we usually say? We say that, if in doubt, take it out. Simple as that. Alright, so let's get back to our urological injuries. A 22-year-old woman involved in a high-speed automobile collision has multiple injuries, including a pelvic fracture, insertion of a Foley catheter reveals gross hematuria. So we're talking here about most likely extraperitoneal rupture of the bladder, because association of that with pelvic fractures is very high. So in this case, you're going to do a retrograde cystogram, confirm it's indeed extraperitoneal. If it is extraperitoneal, you have already done your treatment, that is Foley catheter. If the extravasation is intraperitoneal, then you take the patient to the OR. That is why some authorities believe that instead of doing a retrograde cystogram, do a retrograde CT cystogram, which will show you extravasation much more clearly. So that's fine. Both answers are correct. You can choose either of them. So this is a cystogram showing extravasation of contrast. You can see on this, you can't tell whether this is confined to the anterior abdominal wall or whether it is undergoing intraperitoneal. There's no problem. I can't tell you whether it's intraperitoneal space till I see the lateral view, right? That is why I think a CT retrograde cystogram is probably a better thing to do. And if Dr. Amal can find us a picture of CT retrograde cystogram, that will show you clearly whether it's intraperitoneal or not. Because in one plane, it says it's intraperitoneal space, but I can't tell you. Looking at it anteriorly, it doesn't. Maybe it's in between the loops of small bowel. Is that what they're trying to say? Anyway, you got the idea. A patient involved in a high-speed automobile collision has multiple injuries, including rib fractures and abdominal contusions, but no pelvic fracture. Insertion of a Foley catheter shows there is gross hematuria. Just remember this, that if there's no pelvic fracture and then most of the injuries are in the lower rib cage and patient has hematuria, that is from renal injuries. Get a renal contusion. You can see here a perinephric hematoma. Let me show you this. This is a perinephric hematoma. You see a nice picture of a nephrogram. What does it mean? That the renal artery and vein are intact. That means this kind of an injury can be observed, right? You don't need to operate on it. What kind of a retroperitoneal hematoma is this? Zone 2 with a nephrogram positive. Treatment non-operative. Get it? Nephrogram. That's what I was talking to you about. Good. Okay. A patient involved in a high-speed automobile collision has multiple injuries, including rib fractures, abdominal contusion, insertion of a Foley catheter. Let's see what somebody has showing us. We are going to share it. Oh, that's lovely. Look at that. So that's a CT retrograde urethrogram, and you're seeing extravasation of the contrast going around. Let's see. It's going in the anterior abdominal wall. You see that? But in this particular one, let's see. Yeah, that looks more like intraperitoneal. This one is, I'm not certain. Okay, let's see now. That one looks like it's intraperitoneal. See extravasation of the contrast? Very nice. This one is more clearly intraperitoneal because you can see the contrast going between the loops of small bowel. That's clearly showing contrast going into between the loops of small bowel. This one is pretty much intact, no injury actually, normal. Very, very nice. This is the lateral view. You can see that above the dome of the bladder there is extravasation of the contrast. But what is interesting is that it is confined by the layer of peritoneum. Remember my picture? This thing is probably not in the free peritoneal space. Hard to know though. Another example here of bladder rupture, but seems to be, well, it's going all around, so maybe, but you see it's not in the central part, it's traveling in the extraperitoneal space. You can actually treat this one. Anyway, that's a good picture. Look at this one now here. You got a catheter going into the bladder, and you got the urethra here, and you know that the bladder rupture can happen here, or it can happen in the penile shaft. Those are good pictures. Thank you very much for sharing. Anyway, so a patient involved in a high-speed automobile collision has multiple injuries, including rib fractures and abdominal contusions. Insertion of a Foley catheter shows that there is hematuria and retrograde cystogram is normal. CT scan shows renal injuries that do not require surgery because there was, nephrogram positive. 6 weeks later, the patient develops acute shortness of breath and flank bruit. What has happened here, guys? Alright, look at this. When you go back to this picture, you will notice that this patient is treated non-operatively, right? Because it's a nephrogram positive. But having said that, look at this laceration. It's going to heal because of the blood in between the two parts, separated parts of the renal parenchyma. And this will allow the renal arterial system and venous system to short circuit and combine to form a arteriovenous fistula. So when you develop arteriovenous fistula, that's how you're going to present in your boards is bruit on the flank, shortness of breath, congestive cardiac failure. This is high output cardiac failure which will lead to the problem. Okay, so it's a renal AV fistula within the renal parenchyma post-trauma. Alright. A 35-year-old man is about to be discharged from the hospital. Oh, by the way, if patient develops arteriovenous fistula in the renal parenchyma and goes into acute congestive cardiac failure, what's the treatment for that? AV fistula, when you form AV fistula, the treatment is surgical correction. Exactly. A 35-year-old man is about to be discharged from the hospital where he was under observation for multiple blunt trauma sustained in a car wreck. It is then discovered that he has microscopic hematuria. In contrast, a 4-year-old falls off his tricycle. In the ensuing evaluation, he is found to have microscopic hematuria. So there's an adult after blunt trauma with microscopic hematuria, and there's a child with, after blunt trauma has a microscopic hematuria. What's the difference between these two cases? The difference is adults having microscopic hematuria is normal. Whenever we get a blunt abdominal trauma, microscopic hematuria is pretty much present in all people. That's not a big deal. The big deal is when you have a 4-year-old child who presents with microscopic hematuria after a fall. Children don't get microscopic hematuria from a fall or from blunt trauma, usually not. So if you see microscopic hematuria in the child after blunt abdominal trauma, think very seriously that there is an underlying congenital anomaly of the renal system, and you must image them either with an ultrasound or with a CT scan. Most commonly ultrasounds are used in this age group. A 14-year-old boy slides down a banister, not realizing that there is a big knob at the end of it. He smashes the scrotum and comes to the emergency room with a big scrotal hematoma the size of a grapefruit. He can urinate normally and there is no blood in the urine. Well, that's why when we all have slid down banisters as children, but we always have our buttocks take the brunt of the attack. We don't slide down facing downwards so that you smush your balls, and that's not the right thing to do. But this 14-year-old idiot did not have any sense and decided to go the opposite end and finally got himself into big trouble. So now he has arrived in the emergency room with a big, huge scrotal hematoma. What is your concern? What are you concerned about here? Yeah, you're concerned about rupture testicle. Not torsion, rupture. You get testicle rupture or fracture of the testicle. And when that happens, what do? How do you confirm the diagnosis, first of all? You confirm the diagnosis by doing an ultrasound. And once the ultrasound confirms the diagnosis that it's not a scrotal hematoma, it's actually an underlying testicular fracture or rupture, then what do? Timothy is saying go to surgery and do what? Repair the traumatic testicle or remove it? Carol? Remove it. Well, Francisco, take it out, and then why do you take it out? Why not repair it? If you take it out, there's just going to be one testicle, and everybody will make fun of this boy. So Olia is saying you can repair it. You can use an implant, okay, but the problem is, yes, you have to do orchidectomy, removal of the testicle that has, one is not good. One is good enough, but when you come and pee in front of another child who is watching you, he will make fun of you and make it famous. That is a one ball boy. A boy with a single ball. That will become a laughing stock for your class, right? Reena, the boys always look at each other. This is Freudian. You know, when you're in middle school, high school, they're always watching each other. That's them. Boys will be boys, Reena. You can't help it. It's natural. So, so the basic thing here is that this child will have, if you preserve the testicle, the spermatozoa will be liberated into the circulation and create autoimmunity against spermatozoa. You know, sperms are not recognized by our immune system as self-antigens. So when the sperms are exposed for the first time to our systemic circulation, the body will form antibodies against the sperms. So although you will form sperms normally from the other testicle, you will have antibodies to, you know, basically neutralize your own sperms. So you're not going to ever be able to father a child. So the best thing to do, this is a true urological emergency, scrotal rupture, before the sperms are liberated into the general circulation, get the whole testicle out and save the sterility of this child for future generations. Okay? Alright, look at this one, huh? Quite impressive. This is a massive scrotal hematoma, and all you have to do is to do an ultrasound to find out whether the underlying testicle is intact or ruptured. A 41-year-old man presents to the emergency room reporting that he slipped in the shower and injured his penis. The examination reveals a large penile shaft hematoma with normal appearing glands. When does that happen? Have you ever known of a person fracturing his penis while taking a shower and slipping? I've never heard of that. Another one is, oh doc, I was peeing and the lid of the bathroom seat fell on my penis. Well, what is the level of your bathroom seat? At what level is it installed in your bathroom? I mean, come on, the lid is miles down from your penis. Unless you have a very special squatting position that you use to pee. I mean, all these funny stories to cover up. The fact of the matter is, David Cohen is saying, David is saying, if you are highly gifted, you may. Alright, that's funny. But yeah, he is embarrassed, Asma, and what he is trying to do is cover up. This is basically during an intercourse with woman on top. It's a classical way of having fracture of the penile shaft. And fracture of the penile shaft is a true urological emergency because if you don't rapidly repair it, it's the tunica albuginea that has been ruptured. So, you know the way the penis gets an erection is because of the flow of blood goes inside the penile shaft and gets trapped inside while the erection is lasting. That ability of the penis to become turgid and erect is due to the intact tunica albuginea of the penis. When you have fracture of the tunica albuginea, your ability to have erection penile erection is lost forever. So this is a true surgical emergency. If something like this happens, these patients need to go to the OR, and you need to repair the laceration or injury in the tunica alvagina to return his penile functions. Alright, now we're going to talk about trauma to the extremities. A 25-year-old man is shot with a .22 caliber revolver. The entrance wound is in the anterolateral aspect of his thigh, and the bullet is seen by X-rays to be embedded in the muscles posterolateral to the femur. A 25-year-old man is shot with a .22 caliber revolver. The entrance wound is in the anteromedial aspect of his upper thigh, and the exit wound is in the posterolateral aspect of the thigh. He has normal pulses in the leg, no hematoma at the entrance site. X-rays show femur to be intact. A 25-year-old man is shot with a .22 caliber revolver. The entrance wound is in the anteromedial aspect of his upper thigh, and the exit wound is in the posterolateral aspect of the same thigh. He has a large expanding hematoma in the upper inner thigh. The bones are intact. So, let me ask you, I'm going to make the diagram. Femur, femur, femur. Case number 1, case number 2, case number 3. Neurovascular bundle, medial aspect of the thigh, artery and vein. The bullet trajectory goes anterolateral, gets embedded here in the case number 1. Neurovascular bundle is medial, bullet trajectory goes like this. Anteromedial aspect entrance wound, posteromedial aspect exit wound, no hematoma, no pulse deficit, no bleeding. That's case number 2. Case number 3, neurovascular bundle sitting right here. Bullet enters anteromedially, exits posteromedially, and there's a huge pulsatile hematoma. Alright. These are the 3 cases, right? Now tell me, out of these 3 cases, which one is the simplest to deal with? 1, 2 or 3? 1. You must be smoking something if you're picking up 2. 1 is the simplest to deal with, right? Injury is in the muscular compartment of the thigh, and that is simple. You don't do anything, give him a tetanus shot, reassure him and send him home. It has missed the neurovascular bundle completely. It's totally out of the range of neurovascular bundle. What about 2 and 3? Which one is more difficult to manage? 2 or 3? Which one is more treacherous? Which one is more devious in nature? 3 or 2? Devious, Niraj, devious. Francisco is right, 2 is devious. 3, what is so devious about 3? Pulsatile hematoma after a gunshot wound to the thigh. Where does it belong? Where does it belong? Is there a mystery about it? It belongs to the OR. Pulsatile hematoma after a gunshot wound to the thigh belongs to the OR because that means the femoral artery has been injured, needs repair. There is no mystery about it. There is no mystery about 1. It doesn't even come near the neurovascular bundle. There is no mystery about 3. It is a pulsatile hematoma. It belongs to the OR. If you don't know how to fix it, there's always going to be a surgeon to, bail you out and take care of your patient. The case number 2 is treacherous. Case number 2 is devious because this is the case where the neurovascular bundle is in line of the bullet but not obviously injured. When you examine it, there are pulses, there is no hematoma, patient looks fine, patient discharged home. Then after about a day and a half, the patient comes back with dead leg. What happened here, Carol? No, we don't have to take the bullets out, my dear, because it causes more injury and trauma. What's the point? Right? Bullets are only taken out if they're sitting right under the skin and are bothering the patients. Otherwise, we leave the bullets well within the body. So, what about case number 2? Patient comes back after 1.5 days of a good examination. You felt pulses, you felt no hematoma, you send him home, you said, you do fine, you're lucky. So, now the patient has come back with a dead leg. What happened here? Francisco Grippi, you should have grasped hold of a vascular surgeon before you send him home, buddy. No, nerve injury will not cause dead leg. Compression compartment affects the nerves, hematoma that compress the vessels. Let me tell you, it's a new concept for you guys. So I'm going to make a fresh page on it. And I'm discussing case number 2 here. So please pay attention, because that's the case that you have no clue as to what is going on. Okay, so I'm going to make a picture. So look at this blood vessels. That's the femoral artery. I've enlarged it for your notice. And it is lined by a smooth single layer of endothelial cells. The smoothness of the endothelial lining ensures that the blood flows in a linear manner without disruption or eddy currents, right? The smooth, single, slippery surface of the normal blood vessel. Now imagine if the bullet travels next door to the artery, doesn't puncture or penetrate the artery, but travels next to it. Can it injure this artery without touching it? Can this bullet injure the artery without touching it? Yes. And how would it do so? Because the bullet has energy waves. Remember? These waves are very important. Energy waves, kinetic energy. And when you get these waves, it simply peels off the endothelium and fractures it. So one of the endothelial lining flips open like a valve, and what happens? The blood dissects underneath this lining and develops a false lumen. Remember the true and false lumen? This is the true lumen and this is the false lumen. Sorry. So there's blood flowing through both these lumens, and initially you're going to feel your pulses are fine. Grossly, you will feel the pulses are fine all the way. Locally, there will be no hematoma. Send this man home, and after 48 hours, 24 hours, what's going to happen here? Invariably, the false lumen will start getting bigger and bigger and bigger to the point where within a couple of days the entire femoral artery will thrombose and blood circulation to the lower extremity will cease. And then when the patient returns, his leg will be dead. And you will be doing an amputation and also going to the court of law explaining your negligence in the understanding of blunt trauma to the arterial tree. So out of the cases number 1, 2 and 3, case number 2 is the most treacherous because you will believe you will have a false sense of security. In case 1, truly it's a simple case. In case 3, truly the injury is obvious and patient belongs to the OR. But case 2 is the one where the injury is in evolution, not visible. So then what do you do if you have to do, if you have an injury where the bullet has gone through, the trajectory of the bullet is in the neurovascular axis, but you don't see any obvious injury? Well, if it is too good to be true, it is, because injury has happened. And how do you figure that out? You figure that out by a concept of ABI, What is ABI? Systolic blood pressure at the ankle joint. Systolic blood pressure at the ankle divided by systolic blood pressure at the brachial. And that should be what? 120 over 120 equals 1, right? So normal ABI should be 1. Anything less than 1 is abnormal. So if your ABI is less than 1, even though clinically the pulses are palpable, but if you really compare the pulses on the upper and lower extremity of the same site, you will notice that the ankle branches have lower pulse pressure than the brachial branches by doing ABIs, ankle brachial index. That screams out trouble for you. And if the patient has ABI of less than 1, you do a Doppler or an angiogram. Both are correct answers for the boards, resulting in you can identify the bleeder and you can then fix it. Okay? So that is an important test question. Now let's get back to our slides, please. So we did that. Let's see, can we go? In a hunting accident, a young man is shot in the leg with a high-powered big game hunting rifle. He has an entrance wound in the upper outer thigh that is 1 centimeters in diameter and an exit wound in the posterior medial aspect of the thigh that is 8 centimeters in diameter. The femur is shattered. In a hunting rifle, if you have this, it's a cone of injury. The whole cone is destroyed and it's obviously a major injury. You require this patient to go to the OR, repair of the bone and repair debridement of the muscles and repair of the arteries. Case number 6. A 6-year-old girl has her hand, forearm and lower part of the arm caught in the ringers of an old-fashioned washing machine. The entire upper extremity looks bruised and battered, although pulses are normal and the bones are not broken. Crush injury to the extremity. In this child, she has a crush injury from a road traffic accident, arrives in the emergency room. What are we worried about? Did we miss case number 4? What was case number 4? Let me see. A young man is shot. Oh, yeah, I missed it. A young man is shot through the arm with a .38 caliber revolver. The path of the bullet goes right across the extremity from medial to lateral sides. He has a large hematoma in the inner aspect of the arm, no distal pulses, radial nerve palsy, and a shattered humerus. So the point of this vignette is if you get an injury like in the upper arm, you have bone injury, you have nerve injury, you have arterial injury. Which one will you fix first? That's the question. Let's first do that. Which one will you fix first? Would you fix the bone first, then the artery? Because the problem is if you're going to fix the artery first and then the bone, then what's going to happen is that the guys who are going to fix the bone are going to come and move the bone so vigorously to approximate them that you're going to end up losing the arterial repair. So you have to just fix the bone first and then go to fix the artery. But the problem is the bones take about 4 to 6 hours to fix, and then you go in and you repair the artery. By that time, what happens to the forearm muscles? They are ischemic, and when you reperfuse them, they develop what we call as compartment syndrome. That means you will have to then do a fasciotomy. So think about how you are going to fix this problem without getting the compartment syndrome. We take a 10 minutes break here and then we reconvene, and I want to see what kind of answers you can bring me. Okay, so you have bone, you have artery, both are injured. What are you going to repair first? If you're going to repair the bone first, then the arterial injury repair will lead to compartment syndrome. Is there a technique where you can avoid the compartment syndrome? Is there a technique? Any leave surgical wound open at the end of surgery. So it's a compartment syndrome. You accept it and you leave the wound open. Now that doesn't do it. So let me show you what happens is brachial artery injury. Typically, a thrombosis, blunt injury to the brachial artery is thrombosis. So you open up the brachial artery, you take the thrombus out, and you put in a stent, a plastic stent, in the brachial artery that reestablishes the circulation temporarily into the forearm muscles, and you secure the stent in place with the help of sutures so they don't slip out, and that brings the blood flow to the forearm, and then you let the bulls in the china shop, that is the orthopedic surgeons, come in, repair the bone, and then you go back in and you do a permanent repair of the artery by resection and reanastomosis, right? So you take the stent out, you resect the damaged portion of the artery and repair the arteries so that now you have a permanent repair. So the forearm muscle will not be under too much ischemia for long periods of time. That is how you avoid the fasciotomies. But if you do happen to have no other options, then of course the bone goes first, then the artery, and reperfusion will lead to compartment syndrome. Now, compartment syndrome is very commonly asked in the boards, and they ask you compartment syndrome in 5 or 6 different ways actually. Last time when I was teaching in New York, I was teaching for New York Step 3, and I had a familiar face there, and I said, I have seen you before. He said, last year you taught me Step 2, Dr. Faruqi. I took the Step 2, now I'm coming for Step 3. And I asked him what was asked. He said in entire general surgery section, he said there were like 12 questions on compartment syndrome. He said compartment syndrome was asked repeatedly in different forms, and I had already taught him about it, so he did it all right, but he remembered the overemphasis on compartment syndrome in your boards, very commonly asked. So typically the board is going to ask you a question about compartment syndrome in various forms and ways, and they're going to always give you pulses are normal, capillary refills are normal. Capillary refill is normal. Is this a compartment syndrome? Yes or no? In other words, can you make the diagnosis of compartment syndrome while the pulses are all intact? Or compartment syndrome is only possible when the pulses disappear? Asma, what do you mean? Somebody is saying no. Yes, no. So no means what? Can you make a diagnosis of compartment syndrome with intact pulses? Yes. Pulses are all intact. The compartment is stiff. What does that mean? No. So for the compartment syndrome to be diagnosed, you have to have absent pulses. Is that correct? No. Think so. No. So even in the presence of perfectly normal pulses, compartment syndrome is possible. Yes? Yes, exactly. That's what I'm trying to say. So that's the point here. Painful, tense, or stiff muscle compartment, normal pulses, normal capillary refill equals so painful, tense and stiff muscle compartment, normal pulses, normal capillary refill is actually compartment syndrome. And what is the treatment of compartment syndrome? Is fasciotomy. So if you don't follow this concept that I am presenting in front of you, and you want to see the vignette talking about absence of pulses before you act to protect the compartment, you're basically acting too late. Once the pulses disappear, it's a dead compartment. You're not saving the compartment, you're amputating the compartment. That's the unfortunate thing about compartment syndrome is they always have very tense compartment. The pulses will be mentioned to be normal, and if you choose to observe, you're done, because amputation will be the next step. Alright, so compartment syndrome can happen from reperfusion injury. Prolonged ischemia with reperfusion after a vascular trauma is one way a compartment syndrome can show up in your boards. Let's go back to our vignettes again. Let's go back to our slides. Thank you. Okay, so we talked about the compartment syndrome in this young guy where the vascular injury can potentially produce compartment syndrome, and I told you the trick. We talked about the hunting rifle accident. Now we're going to talk about the extremity of a 6-year-old girl, hand, forearm and lower part of the arm caught in the wrinkles of an old-fashioned washing machine. The entire upper extremity looks bruised and battered, although pulses are normal and the bones are not broken. What is happening here, guys? So this is a crush injury. Mamta, I'm going to tell you the 5 ways of compartment syndrome as we go along. So I've only mentioned the first way. The second way is actually this injury, blunt, crush injury to the extremity is another way compartment syndrome will show up. So everybody knows that when you have crush injury of the forearm muscles, you develop rhabdomyolysis. And when you develop rhabdomyolysis, what happens is you get hemoglobinemia, hemoglobinuria, and renal failure. You will also get high levels of potassium in the body from liberation of potassium, which can lead to cardiac arrest. So on one hand, you have hemoglobinemia, hemoglobinuria, renal failure. On the other hand, you have high volumes of potassium liberated causing cardiac arrest. And the third way is oxygen-free radical injury. Your dying muscles are going to liberate oxygen-free radicals that are going to destroy they're going to produce inflammation. And the underlying muscles that have undergone crushing injury, they're going to swell up locally. They're going to produce compression and compartment syndrome. And if you don't do a fasciotomy, these muscles may die. So this is the second way compartment syndrome can present. First way is revascular injury, revascularization injury. The second way is crush injury. And crush injury has 2 components, systemic and local. Local component of crush injury is actually compartment syndrome. Systemic component of crush injury is hemoglobinemia, hemoglobinuria, and renal failure on one hand, and hyperkalemia with cardiac arrest on the other hand. So how do you address the crush injury? One part of addressing is to do a fasciotomy to treat the compartment syndrome. The other part is to deal with the rhabdomyolysis syndrome. So what is the treatment of rhabdomyolysis, girls and boys? What do you do then? How do you prevent renal failure? So hydration is important. You're going to give fluids. What else are you going to give? How do you protect the kidneys? Fluids is one part only. There are more. Alkaline the urine. Give them sodium bicarbonate, alkalinization of the urine. How does alkalinization of the urine protect the kidneys from myoglobin crystals? Myoglobin crystals. How do you protect the kidneys from myoglobin crystals? Alkalinized urine, you do not form crystals. The myoglobin urea remains in the liquid form if the urine is alkalinized. In the acidic urine, with normal pH of the urine is acidic, 6.9. In the acidic urine, you will develop crystallization, but in the basic urine, you will not. So that's the reason you want to give them base to convert the urine from acid to base so that the crystals remain in a water-soluble form and get flushed out from the body. Diuresis will help And for that, what is a preferred diuretic agent for crush injuries? Do we use Lasix? Do we use mannitol? Or do we use, yes, everybody knows mannitol is the preferred diuretic of choice. And why is mannitol preferred over Lasix and other diuretics? Do you know? There's a reason behind it. Why mannitol? Why not Lasix? Osmotic, okay. What else? That's not the reason. Won't wash out potassium. What else? You want to wash out potassium, Julieta, right? He's hyperkalemic. So you want to shift inward. There's no shift. I tell you what's going on. Mannitol is an antioxidant. Oxygen-free radical injury is the one that causes the patients to get systemically ill. Mannitol is antioxidant. It absorbs oxygen-free radicals. Did you know that? So on one hand, mannitol causes diuresis, and on the other hand, it actually is antioxidant. And being an antioxidant, it is very helpful. The majority of authorities, major authorities on crush injuries of the extremities, believe that mannitol's antioxidant properties are beneficial. Okay, so that's very good to remember. And now we're going to move on. You get a phone call from a frantic mother. Her 7-year-old girl spilled Drano all over her arms and legs. You can hear the girl screaming in pain in the background. What is the next appropriate step in the management of this patient's condition? Number one is bring the patient to the emergency room, to the nearest emergency room ASAP. Number two, dilute the Drano with mild acetic acid. Number three is wash the baby in running tap water for 15 minutes before coming to the nearest hospital. Number four, give the baby a lollipop to calm her down till 911 response arrives. What's the best answer? Lollipop. Yeah, you don't have to neutralize the base. Drano is a base. You don't want to put an acid, dilute acid to neutralize. Don't play a chemist. Just make sure that the baby gets irrigated. That if you go into the specificities of chemical burns, they say from the time of contact to starting the irrigation should not be more than 3 minutes. If within 3 minutes you can start irrigating the baby's skin of the chemical, the burn degrees can basically be reduced. So you could have a potentially 3rd degree chemical burn. You can reduce it to a 2nd degree burn if you start irrigation copiously within the first 3 minutes from the onset of the burn contact. So that's the key word here, and I think that's what you need to know about. Immediate irrigation with copious running tap water for 15-20 minutes before you even think about moving the patient to the nearest hospital. Make sure that the clothes she's wearing that are soaked in the chemical must be immediately removed. That's the biggest source of prolonged contact on the skin, is the clothes that absorb and saturate themselves with the chemical and then stay in contact with the baby while you're doing everything else. Remove the clothes immediately and irrigate the body of the contact part of the body continuously with copious amounts of tap water. Okay, tap water, that's fine. Not hot water, not warm water, just tap water. While trying to hook up illegally to cable television, an unfortunate man comes in contact with a high-tension electrical power line. He has an entrance burn wound in the upper outer thigh and an exit burn in the lower part of the same side. Electrical burn will show one burnt spot at the entry point and one burnt spot at the exit point of the compartment. But in between, there's no skin damage. How do you think that burn is? Is it a good one? Is it a bad one? Electric burn doesn't show any external damage, but it's an extremely bad one because electrical burns can actually harm you in 2 ways. Number one, at the time of electrocution, you could die from cardiac arrest. Number two, it can cause demyelination. It can cause blindness. Number three, a local problem will be the burn goes through the muscle compartment and turns the entire muscle compartment into ischemic compartment. because the muscles will swell, become edematous, and develop swelling and edema within the compartment, and it's going to produce compartment syndrome. Right? So this is the third way the board can ask you about the compartment syndrome. The third way, that is the dead muscle within the compartment swells, or inflamed muscle swells, and that leads to compartment syndrome. That's one way. So you have to actually do fasciotomies, and devitalized muscles should be removed, and you should try and save the limb that way. So electrical burns can have systemic causes of death, can have local compartment syndrome and death of the extremity, and you should know that well. And of course, when the patient's muscles are damaged by electrocution, there's also myoglobinemia, myoglobinuria, rhabdomyolysis, all that stuff is going on hand in hand with electrical burns. You got to treat those with hydration, mannitol, sodium bicarbonate, all the things we learned earlier. A man is rescued by firemen from a burning building. On admission, it is noted that he has burns around the mouth and the nose, and the inside of his mouth and throat look like the inside of a chimney. Now we are coming to thermal burns, and thermal burns are of two types. Thermal burns in closed space and thermal burns in open spaces. Which one is a better thermal burn, in closed space or open space? Open space burns are better because you're not going to get inhalational injury. In closed space burns, imagine yourself in a closed space where the building is on fire and you can't escape for 15, 20, 30 minutes till the fireman comes from the window, opens the window and takes you down and out of the building, because within the building there's fire, you can't use the regular paths of exit. This type of burn, where you're trapped inside a burning building, you will be inhaling all the soot particle, all the carbon monoxide that is being produced, and in addition to the heat that is coming in contact with you and thermal injuries that are in contact with you from flames, you will have two types of burn: the skin burns and inhalational injury. And inhalational injury is of two types: inhaling the carbon monoxide, producing systemic toxicity, carbon monoxide poisoning, and inhaling the carbonaceous soot particles that deposit in the moist mucous membranes of our upper airway, resulting in irritation, inflammation, and edema of the airway, leading to bronchospasm, bronchial edema, and occlusion of the airway. So you got a double whammy going on in closed space burns. Inhaling the carbon monoxide, which is a systemically poisonous gas, and it causes carboxyhemoglobin formation, which leads to desaturation of the blood and death of the patient. And the second reason why you get it is because of the carbon soot particles irritating your airway physically, producing edema and swelling and bronchospasm, leading to a shutdown of the airway. So these patients who arrive from a closed space burns, your approach to them is exactly the same as your approach to trauma, life-threatening emergency. How would you proceed? The concept of ABC applies. So intubate these patients and then get IV access and then do the necessary stuff that you have to do. So closed space burns, what is the treatment for carbon monoxide poisoning? 100% oxygen. Intubation will provide you that guaranteed. Closed space burns, they have bronchospasm, bronchial edema and swelling because of the carbonaceous soot particles. How do you overcome that? You've got a tube inside the airway, you have overcome that. So with an intubation, you have covered both the carbon monoxide poisoning part and securing the airway while it is trying to shut down on you from edema, swelling and reactivity. So closed space burns are very important. Okay. Now moving forward. A patient has suffered third-degree burns to both of his arms when his shirt caught on fire while lighting the backyard barbecue. The burnt areas are dry, white, leathery, anesthetic, and circumferential all around the arms and the forearms. So what do you think about this kind of burn? It's an open space burn, happened at the time when you were trying to fire up a backyard barbecue. But you got the burns good and proper because you have circumferential third-degree burns. Third-degree burns are dry, white, leathery, insensate. And when they are circumferential around both your arms and forearms, what is the next appropriate step? in the management of this patient's condition. The eschar, full thickness burns, are called eschars. Eschars have developed, and they have developed circumferentially. In a matter of few hours, what's going to happen with the circumferential eschar over your upper extremities? Fluid doesn't trap in eschars, asthma. Compartment syndrome, exactly. You've got a tight leathery strap of eschars surrounding your upper extremity. Within a few hours, the underlying muscles are going to swell up, and the eschar is rigid. It's like leather, it's not going to swell with it. So what you're going to develop is a compartment syndrome. So this is the fourth way a compartment syndrome develops. Let's recount. Revascularization leads to compartment syndrome. Crush injury of the extremities leads to compartment syndrome. Electrocution burns of the extremities leads to compartment syndrome. Third degree burn circumferential around the extremity leads to compartment syndrome. Have we discussed 4 cases already? Right? They are all asked in the boards, each and every one of them. And what do you do with the eschars that are circumferential leading to compartment syndrome? What do? You do escharotomy. Where would you do escharotomy, Avni? In the OR, on the bedside. Of course, on the bedside in the emergency room, because the patients have no sensation. You can cut the eschar with a fine, sharp blade. Patient won't feel a thing, and you'll open up the eschar, and hallelujah, the pressure is gone. So you don't need to go to the OR, Vikram. It's insensate anesthetic. The nerve endings on your skin on a 3rd degree burn by definition are dead. You don't feel a thing. Alright? Painful burns is alive. Painless burns is dead. You understand? So 3rd degree burns are full thickness burns. They are painless burns. You understand that? So, yeah, escharotomy saves the compartment. Okay? Very important. A toddler is brought to the emergency room with burns on both of his buttocks. The areas are moist, have blisters, and are excruciatingly painful to touch. The story is that the kid accidentally pulled a pot of boiling water over himself. So what do you think about this story? Does it match with the distribution of the burns? Both the buttocks have circular areas of burns. And it says the kid put the boiling water. The kid would put the boiling water, you will have a splash type of a burn, right? These are 2 areas of buttocks that somebody took the kid by ankles and neck and dipped him in hot boiling water to give him the punishment. This is child abuse. So now the board is going to give you a case of child abuse and will ask you what is the next appropriate step in the management of this patient's condition. Choices are: call the police. Number 2, call the child protection agency. Number 3, confront with the parents directly to settle the score. And number 4, call hospital authorities to deal with the situation. What's the best answer? Child protection services are provided by the state. Police admit the child first. Avni, you want to protect the child first, and you're suspecting child abuse. And I didn't give you the choice of admit the child first. I gave you 4 choices. Pick it up. Child protection services is not the right answer. It's the state authorities that do that. State authority, child CPS or child protection services are by the state of California or wherever you are. Police, you're not supposed to call the police. Are you trained? Are you trained in the social interaction? Do you have any knowledge of social situations in a family? You're not familiar with that. You're not trained to deal with the children's, with the family dynamics. You're not a psychologist. You don't have a degree in psychology to understand what's going on. So your job as a surgeon is to identify the child abuse and report it to the social services department of the hospital. Every hospital has a social service provider. You call the social services, they will come, interview the parents, look at the baby, talk about the problems, address the issues, and they are trained how to interview the parents, and they are trained who to call first, the police or to call the child protection services. Because whoever they are going to call have implications on the parent's life. So you have to be out of this and let the social services of the hospital decide that. So social services is basically the hospital authorities in conditions like this. And the board pointedly asked this question. And those of us who choose calling the police or calling the child protection agencies are wrong. You don't take the matters in your own hand. You call somebody who is an expert in dealing with these situations, who will then call the appropriate authorities. And that person in the hospital, staffing, is the social services department, which is part of the hospital, employed by the hospital. So your job is internal consultation. Like, if you have a child with a broken arm, you're going to call orthopedic surgeon, right? If you have a child with acute appendicitis, you will call a pediatric surgeon, right? As a primary care physician, you're not going to do appendectomy, right? As a primary care physician, you're not going to fix the broken bones, you're going to call the orthopod. Similarly, as a primary care physician, you're not going to intervene in the social problems, you're going to call the social services. It's a consultation. It's a consultation. Reason for social service involvement is suspect child abuse. You don't even tell the parents. You take the history, you examine the child, you jot down your findings, your suspicion, and you accordingly call for consultation. Burn consultation, orthopedic consultation, neurosurgery consultation, and social services. That's it. It's your consultation calling. And then they decide what to do. You don't intervene. That's the point. Okay? Okay, very good. Now burns. Thank you, Asma. I'm glad you're getting clarifications here. An adult man who weighs a certain kilogram body weight sustains second, third degree burns in whatever area. The burn will be depicted front, back, da 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 da. So now these vignettes are your typical burn vignettes, and let me give you thermal burns and a little bit of a principle on thermal burns so you guys understand what we're talking about. So thermal burns, we're not talking about chemical burns or electrical burns. Now we are purely addressing thermal burns. And thermal burns are of three types: first degree, second degree, third degree burns, right? First degree, second degree, third degree burn. First degree burn, the best example is sunburn. You come down, visit California, you love the Santa Monica beach. You decide right in the middle of the heat wave to go absolutely nude, lying flat on the white sand of the Santa Monica beach for 8 hours. And you get up and you look at yourself in the mirror, you look like a red lobster. That is sunburn. That is a first degree burn. So now, what are we going to do with the first sunburn? Do they need to be hospitalized? No. Do they need to be taken to the operating room? No. Do they even need to go to the emergency room? Maybe. But majority of the time, if you have a sunburn, the best thing to do is get yourself out of the sun for the next 2 or 3 weeks. Apply moisturizers all over your body. Drink a lot of fluids to keep yourself hydrated. Hydrate yourself, hydrate your skin, protect your skin. That's the reason. Are first degree burns painful? Oh, they are painful. If you've really had first degree burns, they can be quite stingy and painful. And in fact, when you apply aloe vera gel, somebody rating lotion that you apply, usually in the United States we have products where aloe vera gel is mixed with lidocaine or local anesthetic agents. So when you apply it, it not only moisturizes and soothes the skin, it also makes the pain go away because you're applying the anesthetic agent. So it's very painful actually, first degree burn. And you just cover it, and after about like a week or 10 days, the redness and the inflammation settles down and do just fine. But you're not supposed to go back into the sun till this all is happening. Second degree burn is a burn that actually presents with what? What is the most classical appearance of a second degree burn? First of all, is it a painful or a painless burn? It is a painful burn. Blisters and painful, absolute. Bulle, you're trying to say, Julieta, yes. Bulle or blisters, painful, that's a second degree burn. Now the board is going to typically ask you a question. A patient comes in with a hot boiling pot dropped on his forearm and you have blisters all over the forearm. What is the next step in the management? And one of the choices given will be puncture the blisters and slough off the dead epidermis. Is that the right thing to do? Puncture the blisters and slough off the epidermis? Absolutely not. It's your biological dressing. Nature is guarding your dermis. You need protection of the dermis, so the dead epidermis and the bully which are trapping your natural serous fluid is acting like a perfect biological dressing. Don't disturb the bully, don't slough off the dead skin, keep it there, just lavage it so that all the debris, if there is any, is washed off. Don't scrub it, don't debride it, just lavage it. After lavaging it with cold saline, you can then apply topically. What do you want to apply on this burn? Silvadene. It's a cream which is sulfur based, yeah, and it's an antibacterial, bacteriostatic cream. You apply it, it's moisturizing, it's soothing, and it's antibacterial. You apply the cream and cover the cream with a wrap of loosely applied gauze or a roll, and elevate the forearm and teach the patient to do rehabilitation physiotherapy. Move the joints, move the fingers, move the wrist so that it doesn't become stiff. And when do you start rehabilitation, my dear? Avnisha, what do you think? When would the rehabilitation start? As soon as possible. Almost on the same day as the patient gets admitted. Exactly, Francisco. So rehabilitation used to be delayed for a couple of weeks in the past. End results were horrible. By the end of 2 weeks, these patients develop stiffness in the joints. They don't want to use the extremity. The extremity becomes more painful when you use it. You start hammering them right from the get-go, you will notice that they are better off in a few days. So second degree burns are partial thickness burns, which means you don't need to, do you need to do skin grafting for second degree burns, or do they heal without scarring? Can the second degree burn does the second degree burn need a skin graft or heals without scarring? You're right, it heals without scarring because the dermis is not involved, it's only the epidermis, hence the blisters. So all you have to do is to allow the dermis to regenerate the new epidermis, which will come from the bottom of the dermis and populate the skin surface over 15-16 days, and you are done. But during those 15-16 days that the epidermis is regenerating, your job is to prevent what from happening? Infection is the number one enemy. Can a second degree burn turn into a third degree burn if there is superadded infection? Yes. That is why you need to prevent bacterial infection, bacterial colonization on a second degree burn. Hence, do you prevent second degree burn infections by giving IV antibiotics? Is there a role of IV antibiotics in preventing infections in a second degree burn? Absolutely not. The antibiotic use is confined to local antibacterial dressings and creams. And what is the number one? So number one thing about the second degree burn is do not debride. Okay? Cover with Silvadene. Okay? And rehab. Okay? And barrier nursing. That's the key word, barrier nurse. All your patients. Barrier nursing is ritual rooms. A burn victim goes into that room, and with him goes all his dressing materials. With him goes all his IV fluids. With him goes all his dressings and his antibacterial ointments. And outside his room, there will be a trolley of disposable gloves, disposable masks, disposable gowns, and each time anybody, doctor or a nurse, is entering that room, they have to wash their hands, put on these disposable gowns, gloves and masks to enter that room. And when you're done taking care of your patient, changing the dressings, cleaning the, whatever you want to do, and you come out, you take all the disposable gowns, gloves and masks, throw them in the bin outside that room, go to the sink, wash your hands again, and then for the next patient, wear a separate disposable gown and gloves and enter. Barrier nursing, the number one cause of morbidity and mortality in burn units is transferring infection from one patient to another with the help of worker bees, nurses and doctors. And that is the problem we have back in India or Pakistan, where you have burn units and people are lying in the general ward and you are coming and seeing your patients every day and you're transmitting germs from one patient to another and from another to another. And in a week you see the entire floor is full of the same bacteria that one patient had originally. Now everybody has it, and the outcomes miserable. And yes, Julieta, you are absolutely right. One of the worst bacterial infections in burns is Pseudomonas. So when you see your dressings are turning green in color, there's green pigment in the dressing, that's Pseudomonas. You know what's the best way to kill the Pseudomonas topically? What's the best way to kill the Pseudomonas? With what kind of dressing change would you do? Would you change an order from Silverdene to something else when you start noticing first signs of green discoloration? No. It's dilute acetic acid. Pseudomonas hates vinegar. So you take 3% acetic acid for Pseudomonas infection. For Pseudomonas, what you need to do is 3% acetic acid. 3% acid. This green discoloration will disappear within a couple of days. Pseudomonas hates acetic acid. The other agent is dilute hypochlorite, like the common bleach, hypochlorite. You can use that also, and that is supposed to eliminate Pseudomonas as well. So there are various tricks. But if you get the patient becoming septic from systemic bacteremia from Pseudomonas, that's a bad sign. So bacteremia from Pseudomonas is a horrible thing. But surface population of Pseudomonas at the first signs, kill it by changing your orders from Silverdene to acetic acid. Okay? Alright. So that is the second degree burn, and it heals on its own without scarring and contractures in the long run, provided you have excellent nursing and you do not disturb the biological coatings that are protecting you. Okay. Third degree burn is a full thickness burn. So it is insensate because all the nerve endings are gone and all the hair follicles are gone. So this skin is gone, it's dead all the way down to the dermis. And this burn will not heal spontaneously. If you allow it to heal spontaneously, it will heal with excessive scarring and cicatrization, which means you'll develop contractures, especially disabling contractures across the joints. So third degree burn requires the proper treatment of third degree burns is after initial resuscitation, patient goes to OR for surgical excision and coverage. I'm using the word coverage, not skin grafting, because if you have full thickness second degree burn, how much of the second degree burn can you excise and cover at one single setting? Say a patient has 40% total surface burn, all third degree. How much can you excise and cover in one setting? No, Avani, 3 to 5% is too low. Yeah, about 18 to 20% is about right. Timothy, you're right. So, any relations with Sandra, Timothy Bullock? No relations to Sandra? Alright, so, yeah, so Timothy is right. It is 18% maximum. Some people take it to 20%, but 18 to 20% is maximum you can excise and cover, because where do you get the coverage from? Some other parts of the body, and you already have one wound and you're creating a duplicate part of that same wound by taking skin grafts from other parts of the body. So it becomes too much. The patients bleed a lot, there's a lot of pain. They can't tolerate more than 20% at any given time. So if somebody has 40% burnt area, they'll probably need to go to OR at least twice, if not 3 times. If somebody has more surface area involved, then they'll have to go 4 or 5 times, and you can space them out every few weeks. So the moral of the story is that if you have a third degree burn and you have to excise and cover it, how soon should you go in and start doing this? Should you go in within the first few days from the onset of burns when the patient is stable, or should you really wait for at least 2 to 3 weeks before you embark upon surgical intervention? What is your information? What is your knowledge about this? As soon as possible, as soon as the patient is stable, or would you wait for at least 2 to 3 weeks for demarcation and then go in? Well, in the past we used to wait, but not anymore. Nowadays, as soon as the patient is hemodynamically stable, that means within the first 3 days from the time of admission, we take these patients for coverage, and we have found out that the outcomes are much better with early intervention, surgical intervention, than delayed surgical intervention. They do better. Their hospital times are much less, and they have lesser chance of infections. So early excision and skin grafting has better outcomes than late excision and skin grafting. That's decided. Alright, so you do a first, second, third degree burn, you understood what they are, and you can treat them. So a vignette gives you a description of a second degree burn, you can identify it and you can treat it. A vignette gives you a description of a third degree burn, you can identify and you can treat it. You will also know what is eschar, you will also know what is circumferential eschar of the extremity, and you'll know that it carries a risk of compartment syndrome, and escharotomy can be done at the bedside because there is no pain there. Alright, now remember we were talking about all burns, you have to treat them like immediate life-threatening A, B and C, airway, breathing and circulation. In the circulation part, how do you measure the fluid therapy in the first 24 to 48 hours? That is very important, guys, because the number one cause of mortality in the past from burn victims was dehydration. Number two cause was secondary bacterial infections. So Parkland Memorial Hospital, which is in Dallas, Texas, came up with a formula that kind of guesstimates the amount of fluids needed to rehydrate a burn victim. And that formula is named after the place where it originated from, Parkland's formula. And believe it or not, this formula is 50 years old but still being used widely all around the world. Parkland's formula states that total body surface area burnt multiplied by weight in kilograms multiplied by 4. Okay, so total body surface area burnt multiplied by weight in kilograms multiplied by 4. And whatever value comes, you divide it into 2 equal parts and give the first half within the 8 hours from the onset of the burn and the second half in the remaining 16 hours. So Parkland formula basically focuses on rehydration therapy in the first day post burns. Again, it's total body surface area multiplied by weight in kilograms multiplied by the fixed factor of 4. In children, it's going to be total body surface area multiplied by weight in kilograms multiplied by 6. In an adult, it's 4. In a child, it's 6. And when you have this value, you divide it half within the first 8 hours of the onset of pain, of the onset of burns. So somebody has burns at 8 p.m. and they arrive in the hospital at 9 p.m. Now you have to give that first half of the Parkland's formula in how many hours? 7, not 8. Vikram, 1 hour was lost in him coming to the hospital. So now you have you have only got 7 hours left to give the formula. If the patient arrives 2 hours later, it will become 6 hours, so on and so forth. But the remaining half will go over 16 hours, and it's almost always a crystalloid. It's usually normal saline or lactated ringer. And how do you know whether your volume that you're giving is adequate or not adequate? How do you measure? Against what do you measure? What is your barometer that you're hydrating correctly or not? Yes, So you put the patient, you get the patient a Foley catheter, monitor their urine outputs in an early manner, and in an adult, how much urine do you expect to see per hour during your burn rehydration therapy? What is the safe number? Any idea? So 1 milliliter per kilogram body weight per hour. So if there's a 70 kilogram male, you should expect to see 70 mils of urine per hour. Okay, ideally we like to create a buffer of maybe another half or double this number. So you want to see in a 70 kilogram male, you like to see at least 100 to 150 cc's per hour of urine output. So if I give you a case scenario where the patient has a certain degree of burns and you measure it on the Parkland formula, start giving infusion therapy, in the first 3 hours of infusion therapy you see the urine output to be 20, 10 and 12. What do? You stick with the formula or go up on the formula? You upregulate the formula. What if the patient is being given the formula, Parkland formula, and the first 3 hours is making urine 300, 250, 350? You have to downregulate the formula. So Parkland formula is not really the word of God, it's a guesstimate at best. So when you're giving fluids, you have to monitor the urine output against the fluid, and you need to see a 1 mil per kilogram per hour is the rate that you expect. A little bit over is fine, but don't down-regulate and up-regulate based upon the urine output. What about maintenance fluid? I mean, you get the Parkland formula that only calculates what's the burn requirements are. What about the regular non-burn basic requirements for all of us? Well, we all need at least 2 liters of fluid. So you're going to add to the Parkland formula that 2 liters extra of regular fluid. That's the baseline. And Parkland formula doesn't take into account the baseline. You have to add that anyway. So if you're going to give the Parkland formula in addition, you have to add 2 liters. And this is only for the first 24 hours. After the first 24 hours are gone, then you go back to the baseline, 120 mils of fluid given per hour, plus for any fluctuations in the blood pressure, you give them plasma expanders. Okay, so that is how you take care of these patients. So the rest of the vignettes that we are talking about in the burn section here are all related to the Parkland formula and its adjustments. Where does the Parkland formula maxes out, guys? So say for instance, if a patient has 30% burn area, what will be the total body surface area in Parkland formula? Yeah, you're right. So 30% for 30% burn, 40% for 40% burn, 50% for 50% burn, and then for 60% burn, it will be 50%. 70% burn, it will be 50%. So the total body surface area has a limit of 50%. It maxes out at that. So even if you have 60, 70 or 80% burns, the TBSA level or value will always be stable at 50%. You can't give it beyond 50%. Okay, so that's how we cover it, and we talked about the Pseudomonas bacteremia. The role of IV antibiotics is only when there's a proven Pseudomonas bacteremia. Then you give them gentamicin or what have you that is effective against Pseudomonas, but not prophylactically. On a proven bacterial infection in the bloodstream of Pseudomonas, that's the only indication for giving IV antibiotics. Otherwise, all the antibiotic therapy is topical and barrier nursing. Alright, so we're going to take a 10 minutes break here before we discuss further.